Welcome, everybody, this afternoon to our second presentation on dysautonomia. We're so happy to have you. My name is Nancy Barlow. I am the Wellness Coordinator for Parkinson's Resources of Oregon. PRO is a local nonprofit organization serving Oregon and Southwest Washington. We are helping people who have Parkinson's and their families live a higher quality of life, and we have been servicing this area for over 40 years. There are two other staff people on this presentation that I want to introduce. Anna Sangareed, she's waving. She is our program manager out of the Beaverton office. And our other staff person on is Libby Kennard. She is our program lead, and Libby works out of our Eugene office. We're happy to have everybody on board here. A couple of housekeeping, I think you know, we are recording this session today, and I will be sending you the link to access the recording in the next week or so once we get it up and going. If you have questions throughout the presentation, we invite you to use the chat box and type those in, and Dr. Swenson has agreed to answer those at the end of her presentation today. So, getting started, I'm just going to quickly turn it over to Jean, Dr. Donovan, sitting next to me, to introduce Dr. Swenson.
Thank you very much. I thank Dr. Lennie Swenson for joining us today. She is a physical therapist at the University of Utah who specializes in neurological conditions and cardiovascular autonomic dysfunctions in Parkinson's disease. She comes highly recommended by colleagues at Utah, and she is both an educator as well as a practitioner owner of a private physical therapy practice in Utah. Today, she will cover the clinical features, assessment, and physical therapy management strategies relevant to CAD in individuals with Parkinson's disease. Dr. Swenson will further discuss other evidence-based interventions with a focus on non-drug strategies often used in physical therapy to address non-motor symptoms. That's a mouthful. We are very grateful that you're here with us today, Dr. Swenson, and thank you. Please take over.
All right, it's my pleasure. I'm still recovering from a little bit of an illness, so please forgive me if I sip water or clear my throat a little bit. But I'm so glad to be here to talk about this topic. As we go through this presentation, let me see here. Basically, this is kind of the roadmap of what I'd like to follow and cover for this presentation. We're going to talk about like how common is this sort of issue in Parkinson's disease? How might it affect outcomes for people with Parkinson's disease? And then if you can manage to stay awake, we're going to talk about anatomy and physiology just a little bit. This is a very complicated topic, so I'm going to try and keep it like as simple and accessible as possible so we can get like the bigger takeaways of what's going on in the body with these issues. I'm going to talk about clinical assessment. There are formal autonomic diagnostics that I will mention as well. But from a physical therapy standpoint, clinical assessment is something that we can do in a more timely manner and get some results to interpret right away and start acting upon. And so I'll talk a bit about what that testing can look like and how to interpret some of those results. I'm also, as Jean mentioned, Dr. Donovan mentioned to us that I'm going to be talking about some non-pharmacological treatments as well. It's not that medications don't have a place in this, it's just it's not really my scope of practice. And often a first go-to are these non-pharmacological strategies. Then I'd like to touch on some modifications and some adaptations that can be suggested for exercise. And then we'll take some questions. All right. So it's estimated, Goodness, sorry, I just barely bumped this thing and it proceeds to the next slide. It's estimated that up to 50% of people with Parkinson's disease have orthostatic hypotension. This refers to a drop, like a pretty significant drop in blood pressure with positional changes. Um, and it's even presumed that this is kind of an underestimate because this can go pretty highly undiagnosed. Possible outcomes for people with Parkinson's disease and neurogenic orthostatic hypotension, which we'll talk a little bit more about what that is and what that means. But for those folks who have that, there's an increased risk for falls, much higher levels of fatigue and activity and exercise intolerance, cognitive impairments. There's a faster disease progression and time to mortality. And there's also measured and noted higher levels of caregiver burden for those taking care of someone with Parkinson's disease who also has cardiovascular autonomic dysfunction. All right. So this is a very confusing looking picture. It can be a little overwhelming, but I'm going to talk about the autonomic nervous system for a little bit here. Some people accidentally call this the automatic nervous system, and it's actually a pretty good way of describing it because the autonomic nervous system pretty much controls a lot of involuntary processes of things we don't really have to think about making them happen, like your heart beating and your breathing happening and your digestion happening. You don't really have to think about making those happen, they just automatically happen. Um, the autonomic nervous system can get broken down into further branches of the autonomic nervous system. And the two that I'm really going to point out here are the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system is maybe something you've heard of in terms of like the fight or flight part of the nervous system, whereas the parasympathetic is often termed in regard to like the rest and digest. It's kind of the chiller side of the nervous system. But both play an important part in our bodily functions. The sympathetic nervous system is going to get a little bit more attention from us today in terms of its control over like the cardiovascular system. So some neural influences on the cardiovascular system. When we look at the word cardiovascular, we're really like thinking about the heart itself and the blood vessels. And so if we look at the parasympathetic nervous system, um, it does have an effect on the heart rate. It can slow that heart rate down. If we look at the sympathetic activity or that fight or flight system's potential influence on the heart, it can actually speed the heart rate up. And this is important. We need that to happen during activity. We need that to happen a little bit when we have postural changes, like going from sitting to standing. So it is an important part of this function. Um, the nervous system can also have an impact on the vessels, but interestingly enough, that parasympathetic nervous system, the rest and digest, does not have any sort of innervation or any sort of control over those blood vessels. Whereas the fight or flight or that sympathetic nervous system actually can control the ability to constrict those blood vessels and tighten them up. And this plays a really important role in being able to get blood kind of circulating and shunted and diverted toward high priority places in the body. So to kind of summarize some two main issues that can happen within Parkinson's disease. The first here is that loss of connection or communication, the way that those sympathetic nerve fibers communicate with the heart. Like there's a loss of functionality there. And so you can see these images here that look like some colorful blobs stacked on top of each other. But really, we're looking at some group findings of how the nervous system is innervating or kind of activating the heart and working with it. That box that says letter A that's bright red, this is what a fully innervated heart looks like. This is normal. Um, Whereas if we look at the group with the B boxes, these are people with Parkinson disease. And when we start to see more of those green and blue colors sneaking in, that's a loss of that sympathetic or that fight or flight nerve activation with the heart. And so remember that that sympathetic nervous system is what helps activate that heart to increase your heart rate. Okay, so if you're losing that kind of activation, your heart rate's not going to be able to respond as well to certain things as it should. There's also kind of the periphery, the vessels that can be affected as well. Uh-oh, I'm not even touching it, I swear. Um, and so when we're looking at the periphery, those vessels, we need that fight or flight system to be able to release some chemicals into the body that allow those vessels to constrict. And there's a loss of that happening, a lack of that happening in neurogenic orthostatic hypotension and folks who have Parkinson disease. So if you look down here in the corner, on the right bottom hand corner, there's kind of this image of someone lying flat, and then they come up to standing. When we come up to standing, when we go to more upright positions, about a third of our blood volume wants to take a ride with gravity down into the lower legs and feet. And that happens in any of us because there's no one that I'm aware of that's immune to gravity. And so that blood volume wants to drop. Your fight or flight nervous system releases some chemicals. The blood vessels in the lower legs should constrict and squeeze and help send that blood volume back up toward the trunk and the heart and the brain and the head. But there's a lack of that potentially happening in cardiovascular autonomic dysfunction. And so, from a heart standpoint and from a vessel standpoint, there's potentially some things that aren't working the way that they're supposed to in people who have Parkinson disease and cardiovascular autonomic dysfunction. And to really highlight this, I have this image here that looks at like how blood is diverted, what percentage of blood is kind of sent to certain areas of the body when you're at rest versus during activity or exercise. And you can see like the muscles here are at the top. And when you're at rest, only 20% of your blood flow is needed to go to the muscles because there's just not much demand happening when you're at rest. Okay. And you can see like a good chunk goes to the brain. The brain's a very important organ. A large percent goes to the guts, like the GI system. You also have a pretty big percentage at rest that goes toward the kidneys, a little bit that goes to the bones, a little bit that goes toward the skin and tissues. But during exercise, the thing that gets the most highly prioritized are these muscles because the muscles are working. There's a demand placed on them, so they need blood and oxygen delivered to those muscles to be able to keep up with that demand. Like 80% is a very huge percentage of your blood flow that's getting diverted there. And one of the ways it gets diverted there is the heart beating faster and putting more pressure in that system, and vessels squeezing in other areas to help send the blood flow toward the muscles. So if you have an impairment in one or both of those areas, then that demand is not going to be met with the blood and oxygen that's needed. And this is where we start to see really high levels of fatigability and exercise intolerance within this patient population. So how can it present? Um, I think a lot of the medical community is used to listening for things that indicate lightheadedness. Like I feel a little dizzy, I feel lightheaded, I feel like I could faint or pass out. Um, but we kind of do ourselves and our patients a disservice when we only listen for lightheadedness because it's possible to have orthostatic hypotension um, without lightheadedness. It can certainly occur, but it doesn't have to. You can see on the right hand of the slide, there's many, many other symptoms listed that can be present with these big blood pressure drops in the body. So I apologize, I have a little medical abbreviation. LE is lower extremity, so leg weakness and buckling. There can be confusion, disorientation, brain fog, unsteadiness, falls. I kind of mentioned some of that fatigue that can be quite high. There can be shortness of breath, chest pain, head and neck pain that's sometimes referred to as coat hanger pain because the shape of it goes from like the base of the skull across the shoulders and across the upper back in kind of the shape of a coat hanger. There can be nausea, visual disturbance that's often described as like blurred vision, tunnel vision, vision that sort of blacks out, double vision. Um, and then there can be some bladder issues associated with this as well. So, the way that we assess this clinically, this is one version. There's different ways to do this, but this is one version that's suggested by the CDC, where you would lie down flat for 5 minutes. We really don't want to like prop your feet up as much as possible. We really don't want to prop your head up as much as possible. Like if you can get as flat as you can be, that's kind of the best case scenario. But after 5 minutes of lying there where it's quiet, you're not talking, no one's entertaining you, um, you take a blood pressure reading and there would be a heart rate reading. And then we'd also know if you have any symptoms while you're lying there. Then as quickly as possible, which can be hard with Parkinson disease. So often, if we need to, we recruit some family members or we recruit some staff and we help you go right from lying down right up to standing up. No sitting and hanging out in the middle. So we get you up to standing. And within that first minute of standing, we start taking another blood pressure reading. We start taking another heart rate reading. And we also know any possible symptoms that could be coming on. Um, I swear I'm not touching my computer. Um, so, um, those symptoms can be that long list of symptoms that I showed you earlier. It could be any of that. If you're getting more tired, if your legs are feeling more weak, if your brain's feeling more foggy. And then that same thing is repeated at the third minute of standing, where you get a blood pressure, a heart rate, and note any symptoms. So, really, the diagnostic cutoffs that we're looking for in that blood pressure dropping is if the top number drops 20 or more millimeters mercury, or the bottom number drops 10 or more. It doesn't have to be both, it can be either of those drops that happens that can really characterize this orthostatic hypotension. So, this is a pretty good way to do it, but there are some shortcomings to this that I'm going to talk about. I actually use this test a bit more with my patients. It's more time consuming, but there's a reason for that. This is called the NASA 10-minute lean test, where the patient still lies flat for 5 minutes. Then, for a couple more minutes, we take more readings just to make sure things are leveled out, things are staying pretty much the same with your blood pressure and heart rate. And then you come right up to standing and lean against a wall. I do like that from a balance point of view. The wall is super close by. Um, but each minute that you're standing, we're going to be taking a blood pressure, a heart rate, and noting symptoms. And this is up to 10 minutes long. And the reason I like this is because there are different ways to classify or categorize orthostatic hypotension, but a good chunk of my patients actually don't have the abnormal blood pressure drops or the symptoms until it's been like 5 minutes into standing. So if I only do that first test, I'm going to be missing this problem in a lot of the patients. So I like to do these longer stands so that I don't miss anybody who might be having this kind of delayed orthostatic hypotension, kind of these latent findings. So when it comes to interpreting the results, there's always math. We always have to do math. It's my least favorite part is the math. But we are looking for that blood pressure drop either in the top number or in the bottom number, but we can further kind of classify or categorize this type of orthostatic hypotension. And we're going to be comparing non-neurogenic orthostatic hypotension versus neurogenic orthostatic hypotension. And basically, non-neurogenic is referring to these big blood pressure drops that come from a volume depletion problem. And when I say volume depletion, we're talking about blood volume. And one of the biggest reasons for there to be a blood volume depletion problem is dehydration. Once we can get you rehydrated, this problem goes away. Blood loss can be another volume depletion problem. I don't see that quite as much in my physical therapy practice, but it certainly could be another explanation. The most common one that I see is dehydration. That's non-neurogenic. Neurogenic is when the neurological structures that actually help control your heart rate and your blood pressure are impaired. There's a dysfunction there. And so hydration is still important in this patient population, but the reason that the problem is happening is because there's a dysfunction in the neurological structures that help control heart rate and blood pressure. And so there's a little bit more of a math problem here where you can compare the heart rate from lying down to standing up, the difference in that heart rate. And then you divide that over the difference in the top number of the blood pressure in lying down versus standing up. And really what we're trying to get at here is in non-neurogenic orthostatic hypotension, if you experience a blood pressure drop, the normal response for the heart is for the heart rate to increase and try and put more pressure into the system and try and help mitigate and address that drop that's happening. But in neurogenic orthostatic hypotension, that heart has a hard time increasing. Remember that lack of sympathetic, that fight or flight innervation to the heart that can be going on. It has a hard time increasing, and thus that drop is not well addressed or mitigated. So that's all that math problem is really trying to sort out there is how proportionate the heart rate response is to that blood pressure drop. Some other things you can look for in neurogenic orthostatic hypotension are potentially some other signs of autonomic failure to kind of help support the presence of NOH. And this can look like urinary dysfunction, GI dysfunction, and then there's postprandial hypotension listed here. This refers to when you eat something, blood gets diverted to the gut to kind of help with that digestive process. But when people have postprandial hypotension, what happens is there's then a big blood pressure drop resulting from that. A nervous system that's operating the way that it's intended to and that it ought to, you can still have blood diverted to your gut and not experience that big blood pressure drop. So this is something that's more common in a neurogenic orthostatic hypotension. I've kind of mentioned people with NOH are in it for the long run. It's not just a matter of rehydrating you and then the problem's gone. Like you have neurologic structures that aren't quite working the way that they ought to. And so to really highlight this minimal heart rate response to postural change and blood pressure drop. I'm going to sort of talk you through this a little bit. Oops. Okay. I'm going to see if I can get a little laser pointer here. But we have two different tracings of a head-up tilt test. Now, you may have heard this referred to as the tilt table test. If you're going in for formal autonomic testing, which I think is a good thing to do if you're suspecting some of this stuff, it's just the reason I don't focus on this battery of tests as much is the national wait to get into a clinic like this is a year or two. So it's good to be able to do some clinical assessments and start addressing things right away, while maybe you wait that year or two before you can get your autonomic testing. But a tilt table test, essentially you're strapped to a table. You've got an EKG hooked up to you, you have a blood pressure monitor hooked up to you, and you're flat for a while. And then they bring you almost all the way upright on that table and look to see what your heart rate and blood pressure are doing in that position change. So in this first tracing, tracing A, this is a normal response to a tilt table test. So I'm going to orient you to these a little bit. The vertical axis on this chart that's on the left-hand side is looking at blood pressure. These are blood pressure measurements in millimeters mercury. And then the other vertical axis over on the right-hand side is looking at heart rate in beats per minute. The x-axis or the horizontal axis is just time going on in minutes. So as we go from left to right, it's time increasing, longer durations of time. And then within the tracing itself, up at the top, you'll see some black arrows. The first one indicates the beginning of that head-up tilt test. That's when the table brings you upright. And then the second arrow is the end of that test where it brings you back flat. This green squiggly line is the heart rate reading, and this red shaded area is the blood pressure reading. Okay, so let's take a look at this top chart. The tilt table test begins, and we can see like a little dip in blood pressure that happens right here. But we also see, it's hard to appreciate on this chart, but we also see a heart rate that goes from about 60 beats per minute up to 80 beats per minute or so. And that is to help offset this little blood pressure drop that happens. And it does a great job because that blood pressure recovers and it stays fairly maintained throughout the rest of the test. This is a normal response. But if we look at the tracing B, the one below that, and we see that first arrow happens, this is going to be a neurogenic orthostatic hypotensive response to this test. So the patient gets tilted upright, and there's a huge drop in blood pressure that happens, and it stays low and it stays low throughout the entirety of the test. And we might be asking ourselves, well, what the heck is the heart rate doing about that? And the answer is not much. You know, we see little squiggles in that green line, but it really doesn't go anywhere. It stays around that 80 beats per minute the whole time. We should be seeing an increase in that. This is a neurogenic orthostatic hypotensive problem. This is a heart that's not able to rise to that demand and increase to address the problem. So I like to show that it's kind of a nice visual of this issue of blood pressure dropping and a heart rate not responding. Supine hypertension is also something worth mentioning. This is basically elevated blood pressure when you're lying flat, and it's present in about half the people who have neurogenic orthostatic hypotension. So basically, it's defined as the top number of blood pressure being 140 or more millimeters mercury, or that bottom number being 90 or more. It's pretty darn common in people with Parkinson disease. So is NOH. So it's not surprising that these numbers have some overlap. Um, a good way to further investigate this really is also with some 24-hour ambulatory blood pressure monitoring. This is where you wear a blood pressure cuff and it will take your blood pressure whether or not you want it to, like every 30 minutes or so, and can also capture some readings while you're like at night while you're lying down. We need to know if you're having these blood pressure spikes when you're flat. It can happen any time of the day, but nighttime tends to be the most notable because you're flat for such prolonged periods of time. Medication management is not impossible, but it's very tricky if you have blood pressure drops happening during the day and then blood pressure that's kind of spiking and elevating when you're flat. Um, but that starts to get outside of my scope of practice. Ways we can better mitigate this, though, without medication is by elevating the head of the bed by 4 to 6 inches. This doesn't mean like cramming a mountain of pillows under your head. This is like taking furniture risers and elevating the head of the posts on the head of the bed. So the bed's on an incline. If you have an electric bed frame that can move and adjust, that's even better. But you can certainly use those furniture risers to accomplish this task. You can also do kind of a small carbohydrate rich bedtime snack because we know that that blood is going to get diverted to the gut and potentially start to cause a little bit of a blood pressure drop in people with neurogenic orthostatic hypotension. And so that little bit of a drop can help offset when you lie down that desire for the blood pressure to try and increase and spike. You can also talk to your neurologist because some of your Parkinson medication has the tendency to help keep blood pressure a little bit on the lower side. So the medication schedule itself can maybe be adjusted a little bit to help offset some of this higher blood pressure at night when you're flat for longer durations of time. So there are some good non-pharmacological treatments for NOH and cardiovascular autonomic dysfunction. Um, there's a lot. So, and this can get a little bit nuanced. Some of these things are much easier said than done, and that's why I think it's worth working with an expert to kind of figure out the best fit for you. But this is strictly speaking from evidence and research as well. That when it comes to compression garments, compression are useful because they put this boost on that blood pressure system. Like some of these vessels that aren't as good at constricting and squeezing when they should, you get a little bit of a boost on that system with some compression garments. So waist-high compression tights are shown to be the most effective, or an abdominal binder. I find that waist-high compression tights, trying to put those on in a group of people who have mobility deficits is sort of a nightmare. And none of you want it, like, none of us want to see you struggle and go through the fatigue that it takes and the struggle that it takes to get those on. The reality of wearing those is not like the best. So the abdominal binder is a nice go-to because it's easy, it's much easier to put on and take off. It does require adding an extra layer of clothing, so you have to be careful in the summer and stuff to not overheat with it on. But it applies some really nice compression around your midsection to help keep that third of the blood volume from dropping into your legs. Um, so compression is an important part. You wear it during the day, you take it off in the evening, check your skin, make sure there's no damage or breakdown of the skin. From hydration, for some of you, this won't seem like much. For some of you, it will seem like an impossibly high amount, but you want to get around 2 liters of water per day because we're trying to create that volume expansion. If you think of your vessels like a water balloon, if you put just a little bit of water in a water balloon and you try and squeeze it, like nothing much happens. if that water balloon's really full, all you have to do is barely touch it and water goes shooting out of it. So we want your blood volume really full and really expansive, and we do that through hydration. And when it's full and expansive, it's much easier for those vessels to pump it and get it to where it needs to go. Um, Electrolytes are a way to help your system hang on to all of that hydration that you've been working on. So there's kind of a range in the research of around 3 grams up to 10 grams of sodium per day. This is a lot. So if you have generally high blood pressure, you need to speak with your neurologist or physician about this first. Um, but a lot of the electrolyte supplement packets that you add to water can be great. I don't make money off of any of these. These are just examples. There's the LMNT, the Element, Liquid IV, Normalite, Redmond, Vitasium. All of these are examples of kind of higher sodium concentrated supplements. Some people will use salt tablets, but what I find is that those are really hard on people's stomachs. So, you can try to go that route, but it tends to cause some gut irritation. You can also add more salt to your diet. Avoid overheating as much as possible. This means out in the summer, this means when you're doing activity or exercising, this means when you're showering. Because when we overheat, any of us, our blood vessels expand to try and release heat. Um, when you're dealing with expanded vessels that are already having a hard time pumping blood, they're going to be even more of a disadvantage, and your symptoms can potentially worsen with overheating. Alcohol will also potentially cause some issues with that blood pressure dropping. Not good for balance problems either. Um, you want to avoid quick postural changes, like when you get up out of bed or when you stand up from a chair. Like, take your time in that. Don't just pop up and start walking because that often can result in a fall if you're having a blood pressure drop. Avoid the Valsalva maneuver. This basically looks like anytime you bear down and like cut your air off, like, like I see that people do this all the time when they're trying to lift something heavy, when they're trying to work out. But basically, this can also happen when you're trying to perform a bowel movement. People with Parkinson's disease and autonomic function tend to have a lot of issues with constipation. So you need to work closely with your physician to help get that better managed. But you also need to like exhale and breathe while you're having a bowel movement. Otherwise, that Valsalva actually creates a blood pressure drop. You can pass out on the toilet if it's severe enough, or you can stand up from the toilet and nearly pass out and fall. Um, you want to be able to avoid large carb-rich meals as well because of that postprandial hypotension. So a better way to do it is small, frequent meals throughout the day. You can use your muscle pump. This might look like pumping your ankles up and down, which get your muscles in your lower legs to squeeze and help pump some of that blood out of them. You can pump those feet before you sit up in bed. You can pump those feet before you stand up from a chair, do like 20 or 30 times, get that blood flowing. Um, and then you can do a water bolus. So this basically refers to 8 ounces or 16 ounces of cold water that's ingested in a short amount of time. The research kind of varies on its recommendation for how quickly to do this, but it's usually around anywhere from 3 to 5 minutes. And what this does is this puts a little blood pressure boost in the system that can last for up to 2 hours. So a lot of people will do this water bolus in the morning when symptoms tend to be worse. Some people will do it before exercise to kind of prime their system and get it ready to pump blood a little bit more easily. And we'll do it after exercise to try and avoid a post-exercise blood pressure drop that can happen. And then the last thing I want to mention on here is activity pacing. If your muscles have demand put on them It can look like getting dressed in the morning. It can look like going up a set of stairs. That demand requires that blood and oxygen to get diverted over to the muscles to help meet that demand. Otherwise, your body will try to draw on other energy systems that it's not intended to. And then you deal with that fatigue and that activity intolerance. So, any places in your life that you can avoid overexertion and build yourself a little like savings account of energy is awesome. So that can be like sitting down when you do your hair or brush your teeth. Definitely sitting down when you shower, taking a few stairs at a time instead of trying to like plow your way up like all 10 at once. Being able to chunk up activities and also find ways to rest throughout your day helps give you an energy reserve that you can prioritize toward higher demand activities like exercise. And I'm a little bit biased because I'm a physical therapist, but the research backs me on this that exercise is a really important treatment for people with Parkinson disease and addressing like motor symptoms. And it's also important in potentially helping with some of this cardiovascular autonomic dysfunction. And no one wants to feel like tired and depleted of energy all the time. So if you can do all of this, it helps prime your system to better be able to meet the demand that's needed. That 80% of blood flow that needs to go to your muscles, it can help like the hydration, the compression, all of that can help better set you up for success with exercise. Um, when it comes to adaptations to exercise, I will be very straightforward. This is a highly under-researched area. Uh, um, like especially when we're talking about exercise for Parkinson disease and cardiovascular autonomic dysfunction, we don't have a lot to draw from in terms of research that's been done so far. But what we do draw from are other areas of research where we look at the effects of exercise on the autonomic nervous system, on autonomic function. And that can be in healthy adults, older adults, sometimes in other patient populations with dysautonomia. Sometimes we can draw on that a little bit too. But um, I just want to keep pointing this out because there's a lot of like exercise protocols out there for dysautonomia or cardiovascular autonomic dysfunction, but they haven't been studied on you. And so you can't just like check the boxes and try and push your way through these exercise protocols expecting a certain outcome because we don't know what those outcomes are or if those are even like the best recommendations for you. So there is like some flexibility that has to be there and some nuance that has to be there to apply those exercise protocols to people with Parkinson disease and cardiovascular autonomic dysfunction. And on top of that, y'all know like even people with Parkinson disease, y'all are very different in what that journey is like and how you experience it. So when it comes to these recommendations, it's not a one size fits all, but you can certainly try some of this out. The goal during exercise is to not have any symptoms during or after exercise. And I put this slide in here again just to remind you that it can be any of these things during exercise. If your brain starts to feel a little bit more foggy, if your fatigue is starting to feel problematic, if you start to feel nauseated, any of this stuff, like we want to avoid this during and after exercise. Um, so positioning is a big deal when it comes to exercise. And like these recommendations are highly based off of like some of the other dysautonomia exercise protocols that are out there. But again, you know, how that looks specifically for you would need maybe some skilled guidance. But generally start less upright. If you have supine hypertension, don't start flat, don't go flat. But if you don't have supine hypertension, then you can try starting out flat. You can also be reclined or seated or recumbent. Um, you also generally want longer warm-ups. A lot of you have reached out about blunted heart rate responses to exercise. This is because there's poor sympathetic innervation to that heart. And what we are starting to see in some of the unpublished research right now is that it does take longer for the heart to start to increase under lower, more moderate intensities compared to higher intensities. So giving yourself a nice long warm up is a good thing to do. And in the dysautonomia world, we tend to say start low, go slow, and it can feel painfully slow at times. When you're trying not to provoke symptoms and you're dealing with this overtaxed system over and over again, you have to go really slow at first, potentially. Be patient with it. It gets better, but don't like drive yourself into those symptoms. Um, Eventually, over time, what we hope to happen is that you can build up on the continuous amount of time that you can tolerate that lower intensity of exercise. Once you start getting around 20 or 30 minutes and you can do that consistently for a couple of weeks, then you're potentially ready to start pushing yourself just a little bit harder in that exercise program. If you're on a recumbent bike, that could look like speeding up just a little bit or adding a little resistance to the bike. But you're probably going to be dealing with a shorter amount of time as you increase that intensity and you gradually build that time up to be able to tolerate longer durations of time at that slightly higher intensity. And over time, with some guidance, you can start to come to more upright positions, kind of following that pattern. But um, generally, we want aerobic activity, we want strengthening activity. Strengthening activity, positioning is a big deal too. And I'm going to bring up breathing again because we don't want that Valsalva maneuver when you're trying to lift or push something heavy and have a big blood pressure drop while you're trying to do that. Um, so make sure you exhale during exertional parts of your strength training. Um, and if you're on equipment or going through different strength training exercises, make sure you make those transitions slowly because you've potentially just diverted a lot of blood flow to your muscles. And remember, like other areas are shortchanging themselves to be able to make the muscles get more blood flow, and that includes the brain. So, like make that stuff happen really slowly and be cautious, hydrate, do all those other things. Um, but thank you so much for having me here today. I also wanted to thank one of my colleagues. Her name is Erin Sutman. She's a researcher and she's kind of like the exercise physiologist extraordinaire. So she shared some of those pathophysiology slides with me. And also, thank you so much for letting me be here and talk to you about this content. Um, are there any questions?
Yes. So we look in chat. We had a carryover question from our first part, and I believe that you made a point to try to address this. But let's look at this question and make sure you don't have anything else you want to add to it. So, is cardiac blunting, the inability to get the heart rate up during exercise per the 220 age guidelines, considered a possible Parkinson's symptom if other medical issues for this have been ruled out? And is it ever an early symptom before the classic symptoms of Parkinson's show up?
Yeah, this is a great question. So this cardiac blunting is really common in neurogenic orthostatic hypotension. And I'm sure that whoever asked this question was able to gather some of that from the content presented so far. But what I didn't touch on as well is how sometimes this issue can be part of the premotor symptoms that happen in Parkinson disease. So we're used to thinking of other premotor symptoms, things that are kind of like, have any of you seen the like iceberg image for Parkinson disease, where there's the stuff kind of sitting up on top of the iceberg, like the tremors and the shuffling gait? But then beneath that, there's a whole other myriad of symptoms kind of lurking in the water. And these premotor symptoms can include things like REM sleep behavior disorder. A really common one is reduced sense of smell. COVID's made this a little bit more complicated, I think, for us. But this blunted heart rate response, this cardiovascular autonomic dysfunction, is actually being considered one of these premotor or like kind of prodrome symptoms to Parkinson disease. So, like, the answer to that is yes.
Okay. Okay. Thank you for answering that. If you aren't going to jump back into your slides at all, you could stop sharing and we could see
Okay.
your face better. There we go.
Oh, you know, if you want to see that or not, I don't know.
Okay. The next question we have on that one slide of symptoms that you had, microvascular angina, is that chest pain? Is the question.
Oh, let's see.
It's Marge Lee.
Oh, the chest pain, I don't know that it's pointing toward angina is specifically, but often people will complain of like shortness of breath or chest pain because some of those lower lobes of the lungs aren't getting enough like blood and oxygen perfused into them. Um, so I don't know that I could coin that differently, but yeah, I hope that helps answer the
Okay.
question to some extent.
Okay, thank you. And
Mhm.
then the question after that says, for treatment of NOH or cardiac blunting, what credentials should we be looking for in a physical or OT professional?
Yeah, this is a tricky one, because there's not really like in the physical therapy world, you can do like board certified specialties and take a really long test to show that you have like a specialty in neuro or cardiopulmonary. Um, but I think we're all really behind on the times where we act like the nervous system and the cardiopulmonary systems are two totally different things. And they're actually things that interact and function together on a regular basis. So I would just ask a given provider, like, what is your experience with dysautonomia? Um,
Excellent.
and and that might tell you what you need to know because, you know, some providers are very teachable, and if you give them some materials, they're very willing to learn and engage, and we need more of that. But if you're kind of hitting a brick wall with someone who looks at you with big question marks in their eyes and like brushes you off, that's probably not the right provider for you. But I don't know that there's any like specific credentials for dysautonomia yet.
Yeah. Okay. Thank you. We have another
Mhm.
question that says, is it safe to do a cardiac stress test on a bike?
Um, so this is where it gets a little bit complicated because technically doing a cardiac stress test on a bike, yes, can be safe. And for people with mobility issues can be safer than a treadmill. Um, but if you have other heart health concerns, and if you're working with a team that has no idea that you potentially will have like big blood pressure drops or issues like during that test or after that test, this is where things start to get a little bit messy. Is like my hope is always that when my patients go get testing like that, that neurology knows what's up, that there's communication with the cardiology people who are running this testing so that everyone's on the same page. Sometimes just like a letter from your neurologist or a letter from your physical therapist can go a long way in those circumstances.
That's a really good point, is that we shouldn't assume that that is happening behind, closed doors between the providers, but that we should take the initiative to advocate for ourselves with that. We have a question that says, does extremity edema or excessive yawning indicate cardiac issues related to CAD?
Oh, interesting. Um, I don't know about the yawning. The yawning's an interesting one because I've heard of this as like a premonitory symptom for migraine too. But the extremity edema can certainly be problematic because we're already looking at vessels that aren't like pumping and returning blood effectively. And when you have edema buildup, it's probably compounding that problem in and of itself. Um, like we can see folks with this is hard too because you're people and people can have more than one problem. And so like if you have diabetes, people with diabetes can develop edema and vascular issues, and they can also develop diabetic autonomic neuropathy. And so I would say the short answer to your question is yeah, if you've got edema in your extremities, it's probably complicating some of the issues that you can have with cardiovascular autonomic dysfunction.
Okay. All right.
Yeah.
Thank you. I see one more question here, and it says, is it beneficial to do a thorough warm up when exercising to mitigate the effects of blood being transferred from the brain to muscles?
Um, the thorough warm up is a little bit more geared toward like the heart needing some time to be able to increase a little bit more. Um, one of my friends that I mentioned here, one of my colleagues, Erin Setman, she's been working at the VA looking at exercise responses in people with Parkinson disease and cardiovascular autonomic dysfunction. And what she's seeing is that, like, number one, this 220 minus age is not an accurate heart rate max to go off of at all in people with Parkinson disease and cardiovascular autonomic dysfunction. Um, but also, under lower and moderate intensities, the longer people go, the more their hearts start to respond a little bit more and they get a little bit closer to that age adjusted max heart rate. And so being able to give yourself a longer warm up gives your heart a better chance of like doing what it's supposed to do for exercise. Um, yeah, I don't know that that specifically answered your question, but in terms of a longer warm up, that's kind of my rationale.
Libby, you're muted.
Okay, sorry. Another question says, if you have both type 2 diabetes and Parkinson's, can neurology still deal with NOH? How do you know which is causing the dysautonomia?
Yeah, this is where like that formal autonomic diagnostic testing comes in, I think. Like obviously they're going to really get after you, like your endocrinologist is probably going to really get after you about diabetes management. But that autonomic testing will sort of test for different neuropathies as well as like impairments to your sympathetic nervous system or your parasympathetic nervous system. That would be able to probably parse that out in a more sophisticated way. From a physical therapy standpoint, we'd still have you doing some pretty darn similar stuff. So like that's where my job gets less complicated. But yeah, some of that formal diagnostics would probably help differentiate that a little bit more.
Okay, all right, thanks. And I have, would you encourage core strengthening as well or instead of abdominal band?
Yeah, I would do that in conjunction. Um, when we talk about abdominal binders, it's not like back braces. there's kind of a funny study out there where a maker of a back brace was like, we're going to study this on factory workers. And they made factory workers wear back braces through their whole shifts. And what they actually found was that these workers were more susceptible to injury because they weren't keeping those muscles activated and strong. Um, and so when we look at abdominal binders, they're actually pretty pliable and pretty flexible. So it shouldn't have the same effect as a rigid back brace that's like keeping your trunk held up for you. Um, but as part of a strengthening program, I always add and include like some postural strengthening and stability, some core strengthening and stability. Um, but I guess to answer your question, I would not do that in place of the compression garment, but in conjunction with, I think is great, or to complement. Yeah.
Okay. That's everything that I see in the chat for questions.
Great. Dr. Swenson, thank you so much. There was so much great information in that hour. I can't wait to actually go back and listen to it again just to look and absorb. So thank you so much for being with us and for your time. Before you all hit leave, really quick reminder that March 16th will be our third presentation in this dysautonomia series. Jean, right next to me, Dr. Donovan, will be speaking. She has extensive background in clinical nursing and teaching and administration, but Jean also was diagnosed with Parkinson's and she has been diagnosed with dysautonomia. So she will come from a very personal perspective, and her goal is to help with self-management techniques. So we hope to see you there. You need to register for that on our Eventbrite. So thank you so much, everybody, for
Thank
being
you.
here.
Thank
Thank you,
you.
Dr. Swenson.
My
Thank you.
pleasure. Take care.